Good evening. On behalf of Indian Society of Hematology and Blood Transfusion, I welcome you all for today's 27th Masterclass lecture on lab diagnosis of plasma cell disorder. Faculty for today is Dr. Khaliqur Rahman, Additional Professor Hematology Lab, SGPGI Lucknow. Over to you, sir.
I thank you so much for the kind introduction. Uh, Good evening and welcome to this Indian Society of Hematology and Blood Transfusion Masterclass. Fine. Thank you. So I'll go ahead. So at the outset, I'd like to thank ISHBT for giving me this opportunity. Today we will be talking about the laboratory diagnosis of plasma cell neoplasm. Fine. So when we talk about plasma cell neoplasm, so PCN is a clonal disorder and the proliferation of terminally differentiated B cells or the plasma cells which secrete an M-band. Fine. So in the earlier 2017 fourth revised classification WHO, the plasma cell neoplasm were clubbed in five broad categories that included non-IgM MGUS, plasma cell myeloma, plasmacytoma, monoclonal immunoglobulin deposition disease, and plasma cell neoplasm with associated paraneoplastic syndrome. In the recent WHO classification, which is kind of available online, but not yet, I think the hard copy is not yet out, it has included some of the new diseases and clubbed diseases with similar features together. And broadly, now we have four group of diseases in this plasma cell neoplasm and other diseases with paraproteins. So we have all the MGUS clubbed together, monoclonal gammopathies clubbed together, which includes cold agglutinin disease, IgM MGUS, non-IgM MGUS, as well as a new entity which is known as monoclonal gammopathy of renal significance. The disease related to immunoglobulin deposition, like immunoglobulin related amyloidosis and MIDD, are together. The diseases with heavy chain that secrete a truncated heavy chain without a corresponding light chain are grouped together and includes mu heavy chain, gamma heavy chain, and alpha heavy chain disease. And then finally, we have plasma cell neoplasm that includes plasmacytoma, plasma cell myeloma or multiple myeloma, and plasma cell neoplasm associated with paraneoplastic syndrome. In this entity, we have an addition of ESOP syndrome, and now Tempe syndrome is now no more a provisional entity, and it's a new entity included in this. So when we talk plasma cell myeloma or the multiple myeloma, many times we use these terms together and as in the form of interchangeable, but there is subtle difference. The difference is that when we say plasma cell myeloma, what we are talking is about a bone marrow. So it's a morphological diagnosis of bone marrow aspiration or biopsy where we see bone marrow based proliferation of plasma cells. Fine. When plasma cell myeloma is in addition, we see monoclonal immunoglobulin deposition or the secretion of M-band along with end organ damage or any laboratory finding which is suggestive of myeloma defining biomarker. Then together these are said as multiple myeloma. So for a multiple myeloma, a diagnosis should have a myeloma related end organ damage, or in absence of these end organ damage, we should have a certain biomarkers which is mandatory for defining this multiple myeloma. So what is the etiopathogenesis of plasma cell neoplasm? Well, it is said that a chronic antigen exposure and the antigenic exposed host germinal center B cells have some epigenetic changes along with some primary genetic events that lead to clonal proliferation of these cells. And this is kind of pre-neoplastic condition as MGUS. When these cells gain a secondary hit or secondary mutation, either IGS translocation, c-MYC translocation, P53, these are the secondary events that occurs later in this clonal proliferation. And then these things together form a full-blown multiple myeloma or a plasma cell myeloma. So in the precursor lesions and the plasma cell myeloma, we can have a similar primary genetic events, but the secondary events are uncommonly seen with MGUS and only seen in progression of these diseases towards multiple myeloma. Fine. These neoplastic plasma cells have got a crosstalk between different cells in the microenvironment, and that leads to certain findings and immunoglobulin secretions, bone lytic lesions, angiogenesis, and other things that leads to the clinical manifestation of this disease. So what are the common presenting features? So patients usually present with weakness and easy fatigability that is attributed towards anemia and high serum IL-6 levels. Patients have bone pains attributable to pathological fractures due to increased osteoclastic activity, recurrent infection due to decreased level of normal immunoglobulins. So more than 50-60% of patients of multiple myeloma have low subnormal immunoglobulin levels. They also have reduced T cell function. And when the disease is full blown, replacing all the marrow elements, neutropenia and other things also lead to recurrent infections. Patients have nausea and vomiting because of hypercalcemia and renal dysfunction. They have peripheral neuropathy either due to nerve compression or deposition of immunoglobulin. These patients may have CNS symptoms due to hyperviscosity and sometimes bleeding manifestation because of the immunoglobulins that coat the platelets and the clotting factors, leading to acquired hemophilia like conditions. When to suspect multiple myeloma? So it's elderly patients having bone pains, pathological fractures, lytic lesions, unexplained anemia, history of recurrent infections, proteinuria, hypercalcemia, and hyperproteinemia. If all these things are present, we can suspect a case to be a plasma cell neoplasm. And when we suspect this, we perform certain laboratory tests to confirm the diagnosis, prognosticate, or stage these diseases. Before talking exactly what are the different investigations, laboratory investigation that we do when we suspect a case of plasma cell neoplasm, we have a quick overlook of the diagnostic criteria of this plasma cell neoplasm. Why this is, why I have presented it before, because this table will help us in defining what exact investigation we need. So for a smoldering myeloma, this is asymptomatic myeloma. The patient should have M protein more than 3 gram per deciliter or urinary M protein more than 500 milligram per 24 hours. There must be absence of myeloma defining event. For multiple myeloma, the patient should have clonal bone marrow plasma cells proliferation or a bony or extraosseous plasmacytoma. In addition to that, he or she must have any of the following myeloma defining events or the biomarkers which are myeloma defining. So he may have hypercalcemia, renal efficiency, anemia, and bone lesions, which are classically known as scrap features. Or in absence of these end organ damage, he or she can have a clonal bone marrow plasma cells, which has more than 60%, involved to uninvolved SFLC ratio of more than 100, or more than one focal lesions of MR imaging, at least 5 millimeter or more. So out of these 7, he should have at least one of things along with clonal proliferation of plasma cells. And then if we have plasma cell leukemia, we should have more than 5% or more circulating plasma cells. So if you see the words that have been highlighted in these tables, so M protein, clonal bone marrow plasma cells, hypercalcemia, renal insufficiency, anemia, bone lesions, SFLC, and peripheral blood smears. So we have to evaluate all these things which I have kept in bold to confirm a diagnosis and prognosticate or stage a patients of plasma cell neoplasm. So summing all these together, for the diagnostic evaluation, you have to evaluate for the presence of clonal paraproteinemia that can be done with the help of serum protein electrophoresis, immunofixation, SFLC, urine protein electrophoresis, or the quantitative estimation of serum immunoglobulin levels. We can have evaluation of clonal plasma cells, and for this, we need a bone marrow aspiration and biopsy, a good bone marrow aspiration and biopsy, because if required, we have to subject the samples for flow cytometric immunophenotyping or IHC. For the evaluation of end organ damage, we should have hemogram, renal function test, calcium levels, skeletal survey, etc. In certain special circumstances, we have to do the biopsy of abdominal fat pad or the renal biopsy. And for the evaluation of risk stratification, we should do serum albumin and beta 2 microglobulin assays, which is the part of classical IPSS staging, and the LDH levels, along with the FISH analysis for the high risk cytogenetic abnormality for revised IPSS staging. So, EHA ESMO joint guidelines for multiple myeloma. What are the investigations that are obligatory and what are the optional? We can have this in the form of tabulation. So flow cytometry as such as a part of diagnosis is optional, but it's a very good, potent tool for MRD estimation for in patients who are on treatment or those who want to undergo for stem cell transplantation. Rest all like blood smear examination, serum free light chain, ASP, P, calcium, LDH, etc., are almost obligatory in each of the patients at the time of diagnosis. So starting with the CBC and peripheral smear. So if we do a CBC examination of a patient suspected to have a plasma cell neoplasm, usually the patient present with anemia, which is normocytic, normochromic, and rest other parameters are usually normal in the initial stages. But in the later stages, as the marrow is infiltrated by the neoplastic plasma cells, other cytopenia may also develop. Fine. The peripheral smear typically shows the presence of rouleau formation, where a number of RBCs are stuck together. They're not forming the agglutinate, but a stack form, which is known as rouleau. And sometimes you can see presence of atypical plasma cells in the peripheral blood in cases of plasma cell leukemia. The other most important thing is the serum protein electrophoresis. And this is the migration of charged particles in an electric field. This is electrophoresis. And when we do it for protein, what it does, it helps in separating the protein based on its physical or chemical properties. So the fundamental principle behind this is that the charge of an amino acid can be changed if we change the pH of a solution. So in an acidic solution, these amino acids accept these hydrogen atoms and become positively charged. In a basic solution, these amino acids release OH and becomes negatively charged. So in serum protein electrophoresis, what we do basically, we have a buffer with a pH of 8.6. And as I told in the previous slide, this pH is alkaline, so it will make the amino acids a net negative charge. So all the immunoglobulins at this pH becomes negatively charged. Although the amount of negative charge present on different components of these protein are different. So when these are negatively charged, they will try to move towards the positive side of electrophoresis unit. But this gamma globulin moves in the opposite direction. Why this happens? Because gamma globulin have a relatively lesser negative charge in this pH. So the pull towards positive is lesser. Meanwhile, the positively charged component of these buffer move towards left side. So instead of moving towards anode, these gamma globulins are pulled with those positively charged ions of this buffer towards the cathode end. And this is known as electroendosmosis. So we can, in other words, say that gamma globulins are the weak swimmers. They cannot behold the opposite currents, so they move along with that and move towards the other end while they were supposed to move towards the positive end. Once this electrophoresis is done, the gel card, which is used as a solid medium, is taken out, it is stained, and then we can see the presence of different bands. So typically in our lab, what we do, we have a power pack, you have a unit with a buffer, you have a gel, and you have an applicator. So you put the serum of different patients in different wells in this applicator, then you put it on this gel. We run the electrophoresis unit and these get separated. In a semi-automated system, you have something to stain over here. You don't have to remove the gel. And after staining the gel, something looks like this. So you have different bands of protein. And typically when you put serum, you get 5 prominent or 6 band. This band, which is albumin, which is the most prominent, then you have alpha 1, alpha 2, beta 1, beta 2. They mostly come together kind of thing. And the gamma comes as a hazy, not exactly band, but hazy form because of presence of polyclonal immunoglobulins over here. But when there is presence of monoclonal immunoglobulin, you don't see the smearing kind of thing. You see a prominent band over here. And that's how you say that there is presence of a monoclonal band. Now, if you see a monoclonal band, the other thing that you need to do is to quantitate it because that is important. So how you quantitate it? You put it on a scanner that scan these band based on its density, and this is a densitometer, and then it produces a graph based on the density and area under curve of these histograms will say that the albumin is so much percent, alpha 1 is so much percent, alpha 2 is so much percent, and then you multiply this percentage to the total serum protein and you get the absolute quantification. Fine. So you get total serum protein from a different machine. You say the densitometry plot, which will say that your gamma globulin monoclonal component is this much percent, You multiply that percent to that of absolute quantity of total serum protein, and then you get the absolute quantification of that M band. So as I told, this SPEP gel has got these multiple prominent bands. This most prominent is albumin, the other one is alpha 1, alpha 2, beta 1, and beta 2. They, in majority of times, they come together as a single band, and then you have a smearing of gamma globulin. And these are all the proteins that are present in alpha and beta regions. You have IgG, AMDE all present over here. Sometimes monoclonal IgA moves towards beta region. The other thing that you can do apart from this gel electrophoresis is the capillary zone electrophoresis. This is the fully automated system, and this is based on the principle that it has got a capillary. The interior portion of this capillary has got a strong negative force. So buffer moves in this direction and there is a strong endosmotic flow. Now these proteins do not come towards the anode, they move along with this fluid towards the cathode end and they get separated while they do so. So what is the advantage of capillary zone electrophoresis over the normal gel electrophoresis? Well, it is fully automated. It requires very small amount of sample and then staining, de-staining is not required because what we get in the capillary electrophoresis is these peaks and these peaks define the proportion of these proteins, which can be again taken into absolute terms if we know the total serum protein quantity. And this for the sake of seeing this is a virtual gel data and image is also generated. So, but there are certain disadvantages. Disadvantage that many times this separation of one peak from other peaks becomes subjective. A small quantity proteins, they usually move towards the beta region. And if I say this may be operator or pathologist preference that when you see a gel and band, you are more comfortable as compared to you are seeing multiple peaks. So in our labs also we tried, but we are more comfortable still with the gel electrophoresis. That's how we prefer that. Other important thing is immunofixation to know what is the type of band, whether this is IgG, IgM, or whether this is kappa, lambda, whatsoever. So this again is a kind of electrophoresis, but the difference is that here you have 6 wells for single sample. In the first well, you put the sample. This is for simple electrophoresis. In the other samples, we put anti-sera after the electrophoresis is done so as to detect which type of band it is. Fine. So first we put 20 or 30 micrograph samples in all these 6 wells. Electrophoresis is complete. Then we put IgG, A, IgM, kappa, and lambda, these anti-sera in 5 wells separately. And whichever corresponding band we have, there is immunoprecipitation, and then we can see that band when we stain them with the Comessi blue or amido black stain, whatever we have. Gel looks something like this. So I said 6 wells, so first, second, third, fourth, fifth, and sixth. So these are corresponding to the electrophoresis. G, A, M, kappa, and lambda. G, A, M, kappa, lambda, we add anti-sera against G, A, M, kappa, and lambda respectively. So if an M band is present, it will, immunoprecipitation will occur and anti-G will bind to G and we see the band over here. Fine. So just like this appears to be a normal, we do not see any band. In this condition, we see 2 bands. One is IgG and the corresponding light chain is lambda. The other is IgA and corresponding light chain is lambda. Fine. Similarly, this is IgM kappa. This is IgA lambda. We have multiple bands over here, but all the bands have same immunophenotype. They are IgA lambda. So by immunofixation, we know that which kind of band we are dealing with. Immunofixation, of course, is more sensitive as compared to serum electrophoresis. The other in the list is serum free light chain assay. And what is this serum free light chain assay? So a plasma cell secretes kappa light chain, lambda light chain, and heavy light chain, different kinds of heavy light chains separately. Then inside the cytoplasm, these are assembled to form the intact immunoglobulins. These light chains are always secreted in excess as compared to these heavy chains. So these excess light chains are excreted out through kidney and some amount of it is absorbed in the proximal tubules. All those which are left over are secreted in urine, which is roughly 5 to 10 milligram per day. This absorption varies with the physical activity, age of the patient, etc. So in old age, there are chances that we will get more amount of free light chains in urine because the absorption capacity of proximal convoluted will become lesser in older age. Right. So now, if we want to detect kappa and lambda and we have some antigenic epitope, which is common towards the free and this bound form, it will be difficult to say which one is free, which one is bound. So the method is devised that the epitope which is normally hidden in intact immunoglobulin is chosen. So if we add an anti-sera, it will not detect anything which is hidden in intact immunoglobulin, and it will only bound to the exposed free light epitope, which is in the free form. And that's how we measure the free light chain and free kappa and free lambda light chains. Their normal reference range is over here, and the ratio roughly is 0.26 to 1.65. It varies little with age and with the renal function of a person. So, as told earlier, also a SFLC ratio of more than 100 is one of the myeloma defining biomarker, and that can be taken into account as a diagnostic of myeloma if the patient have clonal proliferation of plasma cells, even in absence of end organ damage. So free light chain, as I said, is more sensitive as compared to SPEP. So SPEP alone can detect 88%. It has got diagnosis at 88% multiple myeloma. But when we add free light, the sensitivity is more than 99%. And if you see, the analytical sensitivity of SPE is 0.5 gram per liter and SFLC is 3 milligram per liter, roughly 100 to 200 times more sensitive as compared to SPEP alone. The addition to armamentarium is serum heavy light chain assay. So this is wrongly written over here. Here, the concept is that when we detect free light chain, free kappa or free lambda, we are not sure that we are detecting the neoplastic kappa or the non-neoplastic reactive kappa, which will go and bind to suppose IgM, IgA, IgE to form. Thus, to increase the sensitivity and the value of involved to uninvolved ratio, this method is devised. So how it is done that every kit or something has got a pair of IgG kappa, IgG lambda, the other pair may have IgA kappa, IgA lambda, other pair may have IgM kappa and IgM lambda. Fine. So first we do serum immunofixation, and if we detect that this is IgG kappa kind of band, then we will use the pair which is IgG kappa and lambda, this one. So IgG kappa, since this M protein was IgG kappa, this is said to be involved heavy light chain, and IgG lambda will be uninvolved heavy light chain. Now we will be detecting this only corresponding to IgG only, not other things. And when we detect the IgG kappa and lambda, suppose this is a normal range, so we calculate and measure the involved to uninvolved ratio. And this assay does two things. First, if we measure IgG kappa and IgG lambda in a particular situation, the total amount will correspond to that of the M protein quantity that we have measured, because that M protein, we said that this is IgG kappa. So IgG kappa plus uninvolved IgG lambda has a greater correlation with the amount of M protein. Number two, the ratio has been used as one of the important prognostic markers. So in certain studies, a heavy light chain ratio of less than 0.01 or more than 200 has got poor performance-free survival, progression-free survival, and a ratio of less than 0.2. These are two different studies published in leukemia. So this ratio has been found in certain studies to be a more robust parameter that can define the overall survival or progression-free survival of the patients. But still, this has not found its place in the diagnostic or recommendations that we currently follow. Urine examination is also very important. Normally, a urine protein is less than 100 milligram per day. In the criteria, as showed earlier, more than 100 milligrams per day is one of the criteria. And if we do serum urine electrophoresis, we do not see different bands that we see in serum. We find a monoclonal band because urine does not have the normal proteins as that of serum. But if we do occasionally, if we have certain hemorrhagic hematuria sample which is processed, we can see a few bands here and there, especially the albumin one. Other blood investigation in addition to these are the ESR, total serum protein, serum beta 2 microglobulin, which is useful marker for the prognostication, calcium phosphate and alkaline phosphatase as a marker for lytic lesion and lytic activity of the bone, renal function test, and LDH levels, which is also a prognostication marker. Serum immunoglobulin measurements are also done, and as I said earlier, more than 80-90% of patients have subnormal concentration of immunoglobulins. Measuring immunoglobulins also helps in certain rare conditions where we find only light chains and no corresponding heavy chain in the electrophoresis. So, mind you, if you remember that serum immunofixation was only done for IgA, IgM, IgG, kappa, and lambda. So, if we find only kappa and lambda in immunofixation without any corresponding G, M, or A, we can say it as light chain myeloma. But before saying that, we have to do this immunoglobulins level because there are rare chances that the patient will have a very high amount of IgD. In that situation, that may be IgD kappa, and because in minimum fixation we are not using this IgD or IgE, we are not able to pick it up. Fine. So in these things, immunoglobulin levels help. Coming to the morphological spectrum, which is again a very I can say a vast spectrum of plasma cells can be seen in different multiple myeloma or plasma cell neoplasm disorders. So normally, if I see a plasma cells, a normal looking plasma cells is roughly a size of a monocyte. It has got eccentric nucleus, clock phased and patchy condensed chromatin, a perinuclear half, and this sea blue kind of cytoplasm that can have some immunoglobulins in the form of Mott cells or the flame cells. These are the normal description of a plasma cells. But when plasma cell become neoplastic, it gains certain features, and seeing even 2, 3, or few proportion of these cells may make you suspicious about the plasma cell neoplasm. So when they become neoplastic, they have got a high NC ratio with relatively central placed nucleus, loss of perinuclear half. There is like presence of prominent nuclei, multinucleation, all these things are there. And I'll show you in subsequent slide different morphology that we have come across while seeing these bone marrow. Fine. So like this, these are the common run of the mill that we usually see when we see a plasma cell neoplasm. All these atypical looking plasma cells, different in size with a high NC ratio. Fine. So we can also have this histocyte kind of plasma cell, like then look like pseudogaucher cell or something. We can have plasma cell which has got multinucleation, flower-shaped cells resembling ATLL kind of thing. We can have some plasma cells with immature lymphoid-looking morphology and some mislabeled as acute leukemia as well. We had one case of oval to a spindle-looking cells, a spindle cell myeloma. You can have a small cell myeloma, which are usually positive for cyclin D1 and 11-14 translocation. You can have certain plasma cells, very large, coalesced plasma cells looking like a megakaryocytes. Sometimes you can have a plasma cells which has got figure of 8 with prominent reddish, I'll say granules suspicious of APML kind of thing. So all these are the morphological spectrum, and definitely when we will scroll a lot, you find certain features that will help you out in defining that these are plasma cells and not something else. But there are certain situations where you have to rely on the IHC or the flow cytometric immunophenotyping to say that these are plasma cells. So they can be of varied morphology. Bone marrow biopsy plays a special role in myeloma because plasma cell disorders are by default have a very patchy involvement. So there may be a chances that aspiration may show you only 2 or 3 plasma cells, and when you see the biopsy, you can have one core or one portion which has got normal looking marrow spaces, and another core which has got these infiltration by monotonous population of cells. And when you do IHC, that will help you identifying these cells as plasma cells having CD138 positive with monoclonality towards lambda. Similarly, they will also help you out when there is some interstitial involvement of plasma cells, or when you want to see their post-treatment, you have to use IHC along with kappa lambda markers that will help to say that these are the clonal plasma cells. Many times these kappa lambda do not work very well, so you have to take it with a pinch of salt. And using IHC for CD138 maybe provide you a better modality to exactly enumerate the plasma cells proportion in a marrow. Amyloid deposition is also seen in bone marrow. It can be seen as extracellular deposit or near the vascular intimal deposition. Coming to the role of flow cytometry. So multicolor flow cytometry, as I told you, it's an optional thing at the time of diagnosis, but in certain situations where the morphology is really deceptive and you are not able to identify these as the plasma cells, you can take help of flow cytometry to confirm that these are plasma cells or rule out if you have something other in mind. So this flow cytometry helps you to identify the plasma cells present in the sample, which is representative. It also helps us in confirming the clonality of plasma cells. In addition, an important role is to discriminate between the normal and aberrant plasma cells. So if you see 20% plasma cells in a marrow and you see more than 98% abnormal plasma cells, then those patients are going to progress relatively rapidly as compared to those which are having more than 5% normal plasma cells. And this is known as MGUS phenotype. So these things are used in certain clinical situations. And of course, MRD is very useful. Multiparametric flow cytometry is one of the most important and widely used modality for the MRD evaluation in the multiple myeloma patients. So how you identify the plasma cells? The classic gating strategy is you see certain cells which are co-expressing CD38 and CD138, and then those cells are slightly dimmer for CD45 as compared to normal lymphocytes. So CD45, 38, and 138 are the markers which are commonly used to identify the plasma cells. Once you identify these plasma cells, then you see the expression pattern of different antigens to say that this is a normal plasma cell or the abnormal plasma cells. Fine. Additional gating strategy to identify the plasma cells like CD229, 319, 184 have been used, and these have found their role in conditions where the patients are treated with anti-CD38 directed therapy, daratumumab, where these cells lose CD38, and CD38 being one of the most useful marker for gating cells, it becomes now difficult to identify the plasma cells together. So CD138 in addition, in combination with CD229 and 319 can be used to gate these plasma cells when a targeted therapy is used. So what are the immunophenotype of normal plasma cells? Normal plasma cells have co-expression of 38 and 138. They are they dimly express 19. They do not express 20 and 22. They are consistently negative. 27 is expressed, 28 mostly negative, 45 is a little variable. 56 is mostly negative, a strong expression with a loss of 19 defines it to be an abnormal cell. CD117 is consistently negative, and this is one of the important neoplastic marker for a plasma cells. Cytoplasmic immunoglobulins are polyclonal and at high levels in the plasma cells. So these normal phenotype act as a frame of reference when we analyze plasma cells with the help of flow cytometry. So just to give you an example, these are the normal plasma cells, 38, 138 positive. They are dimmer as compared to these lymphocytes. They are positive for 81, positive for 28, negative for 117, mostly negative for 56, but you can see some small amount of 56 over here. We will see to it later what are these, whether normal or abnormal. Then they are positive for 19 and 38, etc. Fine. So they have slightly higher side scatter similar to that of monocytes, slightly dimmer 45. And then these are polytypic, kappa over here, lambda over here. So there is no clonal restriction. These are polyclonal in terms of light chains. So these are the features of normal plasma cells. I was talking about this proportion of cells. A small subset of plasma cells do express CD56, but as compared to these 19, they have similar phenotype. If you see anywhere, they are also, these blue populations also polytypic. So they say that this 56 is not always abnormal. A small subset of plasma cells are 56 positive, but those are polyclonal. So we have to take these things into mind. And that's how utility of kappa and lambda in a flow cytometry becomes one of the useful things to define the clonality of these small subset of plasma cells which can express CD56 and can be dimer CD19. Similar situation that to say different subset of these cells, if you see in 1956 plot, one population 19 positive, other population 1956 both positive, third population 56 positive negative for 19, and fourth population 1956 dual negative. But if you see these things, all these four population are nicely polytypic in cytoplasmic kappa and cytoplasmic lamb. So these are different subsets, subpopulation, but not the neoplastic one. So what are the immunophenotype of abnormal plasma cells? I told you earlier, 19 dim or negative, 56 aberrantly expressed, 117 aberrantly expressed, loss of CD81, 27, overexpression of 200, and immunoglobulins being monoclonal. These are the features of abnormal plasma cells. Just to exemplify, these are 38, 138. If you see 45 versus 38, for this population is 45 almost negative. We get these cells in two different colors. This green appears to be the normal one, red appears to be the abnormal one. Now, this abnormal one is nicely positive for 56, bright expression, but negative for 19. This is an abnormality. They have lost 27, lost 31. They have gained 117, and now they are cytoplasmic kappa restricted. There is no lambda expression. So these are the abnormal plasma cells. And this green population we see, this is also 56 positive, nicely negative for 19. Now, if we divide these population, we have 1, 2, 3, 4 subset that I told. This subset with 19 positive, 56 negative is cytoplasmic kappa and lambda polyclonal. This subset 19 and 56, which is present over here, is again uh, sorry, this is monoclonal towards kappa, similar to that magenta color population. And this 19 and 56 population, something over here, is polytypic. So this and this population are monoclonal, and this is polyclonal population. So in this way, flow cytometry helps in exactly identifying the plasma cells and say their phenotype, and also say what proportion of the total plasma cells are neoplastic. Fine. So I'll skip this. So the markers that were studies to identify abnormal plasma cells are these. And what is were found that presence of studying CD138 along with these 7 markers help you identify the abnormality in the plasma cells up to 97%. Additional marker do not have any discriminatory power, and the cytoplasmic kappa and lambda confirms the presence of clonality. So in a typical flow cytometric assay for the plasma cell disorders and also at the MRD analysis, you use these 8 markers along with kappa and lambda to say that this plasma cells, whether in a small amount or large amount, is normal or abnormal. Another important thing that flow cytometry can do is a ploidy analysis. So ploidy analysis with the help of a dye which is FX cycle violet can be used. This is the nuclear dye that binds to DNA fragments. And we compare the mean fluorescence intensity of this FX cycle with that of lymphocyte. A ratio of 0.95 to 1.06 is taken as diploid. Less than 0.95 is hypodiploid. More than 1.16 is hyperdiploid. And these things have been validated in several studies. We also have done this in some of the patients. So this is one of the added advantages of flow cytometry, which can be used in case we want to see the ploidy of the plasma cells. Coming to genetic analysis. So as you all know that plasma cells is a genetically heterogeneous disease. Myeloma cells have a low proliferating capacity, hence the conventional karyotype that needs a metaphase is many times difficult in a plasma cell neoplasm. So the genetic abnormality can be detected easily with the help of interphase FISH, which is the more sensitive than the conventional karyotype. And if we do properly with the CD138 selected plasma cells, we detect abnormality in more than 90% of the cases. Some genetic aberrations which are seen are supposed to be the recurrent primary genetic events in plasma cell neoplasm. And while the others are the secondary events that are mostly seen in the time of progression. and they are very infrequent in the MGUS or smoldering myeloma, the asymptomatic one. So the recurrent genetic abnormalities in multiple myeloma, the numerical abnormality in the term of hyperdiploid or hypodiploid is seen, and hyperdiploidy typically with odd number of chromosomes is noted. Then we have a structural abnormality in the form of translocation, where IGH at chromosome 14 is commonly involved with a different translocation partners. The five common translocation partners are the cyclin D1 on 11, FGFR and MSET at chromosome 4, MAF at chromosome 16, MAFB at chromosome 20, and IRF4 at chromosome 6. These are the five most common partners in case of IGS translocation. The secondary genetic events that are seen at the time of progression and mostly in multiple myeloma, not in MGUS and smoldering, is the MYC translocations, the deletions 1P, deletion 17, and 1Q amplification. These are the secondary genetic events that are seen in the subsequent phase of plasma cell neoplasm. So the consensus panel, the question arises what all to include and what all not to include. So the consensus panel says to include these 7 aberrations using interface FISH for the patients of plasma cell neoplasm, multiple myeloma. These all red are the minimal abridged form which should be used for the patients, and these all define a poor prognostic group. So minimum that we have to identify for the sake of staging our IPSS is using these, at least these 3 or 4 for the defining the high risk category. So a case courtesy Dr. Manish, who takes care of our FISH and cytogenic lab, is like this. Translocation 414, you can see the dual fusion signals in the form of VELO, and then you have amplification of 1Q. So you have one probe against 1P and 1Q. You see multiple red signals while only 2 green signals. So there is amplification of 1Q. Just a word about multiple myeloma staging, or IPSS. So I talked about the FISH that should be used. So in the earlier used ISS that do not included these genetic aberrations had only serum beta 2 microglobulin and albumin levels, which says low stage and low standard and high stage. When we include cytogenic abnormalities and say that these 3 are the commonly involved high risk things along with the LDH, if these are present, they directly go to the high stage, and if they are absent, they are stage 1. There is difference in the overall survival in the 5-year PFS, and that's why these are important to be done for prognostication of the patients. What is the role of NGS in sequencing? So as of now, the staging of the patient and the diagnosis, whatever is required, is satisfactorily and routinely being performed with the help of FISH. But definitely there are certain things, some cryptic translocations, some CNVs and TP53 mutations, which is important to define a biallelic TP53 inactivation, is not possible with the help of FISH, and that's how you need the next generation sequencing or high throughput sequencing. It also helps you in understand the pathogenesis better. Presence of certain somatic mutations are a feature that can be used for personalized therapy if you have a targets available for them. And definitely one of the most common use of next generation sequencing is monitoring of multiple myeloma patients, the monitoring of MRD. Renal involvement, plasma cell neoplasm, 1 or 2 slides. So there can be different spectrum of renal cell involvement. The CAS nephropathy as a deposition of light chain is one of the common. And for detection of these, you need renal biopsy supported by electron microscopy and immunofluorescence. So these things are required to see the spectrum of renal involvement in plasma cell neoplasm. So just to summarize, plasma cell neoplasm is a very heterogeneous disorder. It has to have multimodality investigations required to diagnose and certify different disorders correctly. The most important and the mandatory ones are to establish the presence of paraproteinemia and the quantity, to establish the clonality of plasma cells and their quantity as well, because these things are the defining criteria of different categories like more than 3 gram per deciliter of protein and more than 10% donor plasma cells, the SFLC ratio, and MRI to detect the presence of a myeloma defining event, which is more than one lesions on MRI, more than 5 millimeter in size at least. So these all things are mandatory for the diagnosis of plasma cell neoplasm. With this, I thank you and I invite you for this forthcoming flow cytometry Indo-US workshop, which is going to be organized at SGPGI Lucknow from 2nd to 4th February. You can go to the website and register this, and thank all my colleagues for this. Thank you so much for the patient hearing.
Thank you, sir, for a wonderful talk. Now I request all the delegates, if you have any questions, kindly raise your hands.
Yeah, hi everybody.
Hi, sir.
Yeah, actually my question is very simple. At general physician level, what are the red flags which will point me towards thinking that okay, this may be a plasma cell dyscrasia, that kind of thing? Okay. As a
So,
general,
sir, I told that if it's an elderly patient who is like anemia not being explained, if it's having good diet but still having persistent anemia, some body ache, weakness, and many a times plasma cell neoplasm are referred to a hematologist from a nephrologist people. The patient goes to a nephrologist with a continuously high creatinine of 2.3 something kind of thing. Nothing else is found. So in these situations, if you have an elderly patient who is having weakness, fatigue, anemia, or unexplained high serum creatinine or something, we can suspect this multiple myeloma thing. Fine. And the order of investigation that we suggest many a times, like in a hospital situation like us, doing a bone marrow examination is easier. So people send the patient for bone marrow examination. But I suggest that first, do the non-invasive investigation. You suspect anything, go for simple total serum protein, albumin, globulin ratio. If you have suspicion, you go for serum electrophoresis or something. Bone marrow examination, being an invasive, should be done after certain investigations are there. Fine. So, any elderly patient presenting with non-explained anemia, weakness, body ache, and a renal dysfunction kind of thing, high serum creatinine value should be investigated in terms of multiple myeloma, but start with non-invasive investigation and then go for bone marrow examination.
okay. Thanks a lot.
Welcome, sir.
Any more questions?
Good evening, sir.
Good evening.
Yeah, sir, thank you
Yes,
so much
Deep.
for this wonderful lecture. Sir, I wanted to ask about, sir, what is this light chain dimerization, sir? How does it affect our utilization of SFLC, sir, and how common it is, sir?
So sorry to say, I've got not much idea about that.
Okay,
We
okay,
will
sir.
discuss in the department. Yeah.
Yeah, yes, sir, yes, sir. Thank you, sir.
Any more questions? So I think there are no more questions. Can we wind up for the day?
That's fine with me. Yeah.
Thank you very much, sir, for your time.
Thank you so much. Thank you. Thanks all. Thank you so much.